Good evening, and thank you for joining. My name is Kim Lynch, and I am with Plexus Communications. Thank you for participating in today's webinar. Before we get started, I have just a few details to go over with you. This program is accredited by Rush University for physicians, nurses, and pharmacists. In order to receive credit for participating today, you must complete the online evaluation form. You will have a few opportunities to do so. I will be putting a link to the evaluation form in the chat section of today's webinar. Also, at the completion of this webinar, the evaluation form will pop up in a new tab for you to complete on the spot. Lastly, we will also be emailing you a link to the evaluation form tomorrow. Once you complete the evaluation form, you will be able to save or print your certificate. You have 30 days to complete the evaluation form. Importantly, on the evaluation form, we have included some helpful links to some helpful handouts for you to download. We especially encourage you to download the brochure from Cooley's Anemia Foundation. We would also like to thank BMS and Chiesi Pharmaceuticals for providing educational grants to support this program. We would also like to give a special thanks to Sandy Gilbert and her team at the Cooley's Anemia Foundation for partnering with us on this project and for helping us to implement today's program. Today's presenter has included some polling questions into his presentation. Whenever there is a question on one of the slides, we will launch a poll for you to respond to. Please take a few seconds and respond to the poll when they appear. Your responses are anonymous and your participation is much appreciated. Finally, if you have any questions for today's presenter, please type them into the Q&A section of your platform, and we will ensure that the presenter sees them. At this time, I have the pleasure of introducing today's presenter, Dr. Sujit Sheth. Dr. Sheth is the Chief of the Division of Pediatric Hematology Oncology and Professor of Clinical Pediatrics at Weill Cornell Medicine and attending pediatrician at New York Presbyterian, Phyllis and David Komansky Children's Hospital and Weill Cornell Medical Center. He is also the Vice Chair of the Clinical Research in the Department of Pediatrics at Weill Cornell Medicine. Dr. Sheth is board certified in pediatrics and pediatric hematology oncology, and he is an expert in iron metabolism, thalassemia, and sickle cell disease. Thank you and welcome, Dr. Sheth.
Thank you very much, Kim. It is indeed a pleasure to be presenting today, and I welcome all of my friends at the Cooley's Anemia Foundation. As you can see from this slide, definitely a lot going on with this foundation, a lot of benefits to being a part of what the foundation does for patients as well as for providers. These are my disclosures. I will be discussing towards the end some not yet FDA approved therapies which are in clinical trials. These are the learning objectives for today's activity. I will provide an overview of our understanding of the disease and its management in 2021. We will discuss the safety and efficacy of the different iron chelators used for treating iron overload in patients with beta thalassemia. We will identify patients who are good candidates for stem cell transplant, discuss the safety, efficacy, and medical need of novel therapeutic approaches like the use of erythroid maturation agents, which are actually approved now, to reduce transfusion burden in patients with beta thalassemia. We will talk about the safety and efficacy data on emerging gene therapy strategies and the various clinical trials that are ongoing. And finally, talk a little bit about models to enhance patient education and empower young patients to adequately manage their illness and transition to adult care settings. So thalassemia is a quantitative hemoglobinopathy. It is essentially a disorder of ineffective erythropoiesis that results from gene mutations that lead to a decrease or absent production of specific beta globin chains. This is different than the qualitative hemoglobinopathies, which include mutations that result in structural abnormalities in the globin chain, such as hemoglobin S, which causes sickle cell disease, hemoglobin C, E, and other variants. Thalassemias are alpha, beta, gamma, or delta thalassemias, depending on which genes are mutated. And this is the worldwide distribution of the thalassemias. It's estimated that approximately 1.5% of the Earth's population is affected by this gene, one of these genes, 80 to 90 million carriers worldwide. Approximately 60,000 individuals are born annually with this disease. The exact prevalence in the United States is not known, but is estimated to be about 2,000 individuals. The estimated prevalence in Italy, as a comparison, is about 6,000 individuals. However, the highest prevalence is in Asia, South and Southeast Asia, including the Indian subcontinent, all the way through Laos, Vietnam, Cambodia, Burma, Thailand, into China as well. However, now it is pretty much a worldwide disease, even though this map does not include other parts of the world like North and South America. But immigration patterns have led to the prevalence of this disease in all countries virtually in the world. There is some correlation between the genotype and the phenotype for this disease, and it ranges from a mild condition where you have anemia at the sort of low end of normal, or a mild anemia. And this is what you see with alpha thalassemia or beta thalassemia trait or minor. And then the most severe on the right-hand side is the transfusion-dependent individuals who have either alpha thalassemia major, beta thalassemia major, severe hemoglobin E beta thalassemia, or severe hemoglobin H constant spring. And then somewhere in between are these non-transfusion dependent individuals with an intermediate severity, with moderate anemia and various other complications, mostly related to the ineffective erythropoiesis. And that includes alpha thalassemia intermedia, hemoglobin H, beta thalassemia intermedia, dominant beta thalassemia, hemoglobin H constant spring, and hemoglobin E beta thalassemia as well. So essentially, even though these disorders are classified into the quote unquote benign hematology section, they're not really that benign. There's a lot of morbidity that occurs, and we'll talk about those morbidities in a minute. So we'll focus now really on beta thalassemia, since that has the highest burden of disease, at least in the developed world. And a lot of clinical trials are ongoing for beta thalassemia specifically. Before we go to beta thalassemia itself, let's talk a little bit about normal erythropoiesis. This occurs in two stages. You have early stage erythropoiesis, which is the proliferative phase, as you can see on the left-hand side, where the hematopoietic stem cell goes through BFUE, CFUE, to form the erythroblasts, and this is really regulated and promoted by erythropoietin. And then late stage erythropoiesis is really differentiation and maturation, which goes from the proerythroblast through a variety of different stages to form the red blood cell at the end, and that comes out of the bone marrow and goes into the circulation. Hemoglobin starts to get made about the basophilic erythroblast stage, and then as that erythroblast matures, more and more hemoglobin is formed, and the nucleus eventually gets tossed out, and the red blood cell is formed. So that's normal erythropoiesis, and the late stages are regulated by members of the TGF-beta superfamily of ligands, which will have relevance when we talk about some of the novel therapies later on. When erythropoiesis is ineffective, essentially what's happening is down here, the basophilic erythroblast is not able to start forming hemoglobin because you can't make adequate amounts of one or the other globin. And so that's where you have a maturational sort of arrest, and differentiation does not progress, maturation doesn't happen, and that leads to accelerated apoptosis in the bone marrow itself, and an accumulation of these TGF-beta superfamily of ligands, which again, we'll talk about later on. So the pattern looks very different when you have ineffective erythropoiesis in thalassemia. And because there's a reduced output of hemoglobin, you have fewer red blood cells that are being made, and therefore severe anemia as a result. And so this sort of summarizes the features of ineffective erythropoiesis. There's impaired erythroid precursor maturation. There's an imbalance between alpha and beta globin chain production. Again, you have more alpha being produced, no beta being produced in beta thalassemia, and the reverse in alpha thalassemia. That imbalance results in the formation of toxic hemichromes from the precipitation of the unpaired alpha globin chains in beta thalassemia. This leads to apoptosis of the erythroid precursors, a reduction in red cell survival, and anemia. That in turn leads to an increase in the erythropoietic drive. You have more EPO secretion. That results in extramedullary hematopoiesis, as well as expansion of the bone marrow itself under the influence of EPO. And with more and more ineffective erythropoiesis being driven by erythropoietin, there's also dysregulated iron metabolism leading to increased absorption of iron from the gut, and therefore iron overload as well. So the spectrum of disease, again, thalassemia minor on the left-hand side, mild to no anemia. These are non-transfusion dependent patients, and they're usually completely asymptomatic. Remember, in this situation, you have one normal functioning beta globin gene. The other one is not working, but you're able to compensate and still have only a mild anemia. At the other end of the spectrum, beta thalassemia major, which is beta 0, beta 0. You have a complete absence in the production of hemoglobin A because you don't make any beta globin at all. Severe anemia requiring transfusions starting all the way in infancy. So this is a transfusion dependent condition with lifelong supportive care required. And then in between, you have these other genotypes, beta plus, or beta 0, beta plus, with a decreased but not absent production of hemoglobin A, leading to mild to moderate anemia. Most of these individuals may not be transfusion dependent and may need an occasional transfusion here or there, but over time, non-transfusion dependent patients do progress to becoming transfusion dependent as the severity of the disease increases over time. So there is a significant variability in the severity in this intermediate category as well. And I won't go through this in great detail, but this is a busy slide, and essentially the relative excess of alpha globin chains up here leads to apoptosis of the marrow, as we've seen, ineffective erythropoiesis, extramedullary hematopoiesis, and expansion of the marrow because of increased EPO secretion. The extramedullary hematopoiesis leads to hepatosplenomegaly, occasionally spinal nerve compression. The expansion of the bone marrow leads to bone disease, skull changes, osteopenia, and fractures. As a result of damaged red cells coming out of the bone marrow, you have hemolysis. Both the ineffective erythropoiesis and the hemolysis eventually leads to anemia. The dyserythropoiesis leads to increased absorption of iron from the gut. Anemia leading to red blood cell transfusions leads to iron overload as well. So you have the development of iron overload in both of these situations, which leads to endocrinopathies, heart disease, and liver disease as well. And then the damaged red blood cells do cause a vascular disease as well, particularly in individuals with thalassemia intermedia who are not regularly transfused, whose bone marrows are not suppressed, as well as a hypercoagulable state because of the increased platelet count, as well as the vascular damage. And that leads to thrombosis, leg ulcers, oftentimes silent cerebral infarcts, and the development of pulmonary hypertension. And then the anemia itself leads to a whole bunch of symptoms: pallor, fatigue, exercise intolerance, poor growth in children, and impaired quality of life overall. So a lot of different things that happen mostly as a result of that ineffective erythropoiesis. The course of transfusion-dependent thalassemia, or TDT, involves regular blood transfusions every 2 to 4 weeks, depending on the size of the individual and how many units you can transfuse at each sitting. Splenectomy as needed. We've moved away from splenectomy by and large, but if it is necessary because of a very enlarged spleen or a markedly increased transfusion requirement, then it may need to be done still. Iron chelation therapy, which we'll talk a little bit more about in a few minutes. Hematopoietic stem cell transplantation, which can be done as a curative therapy. And now we have the ability to reduce transfusion burden by using the drug luspatercept, which we will also talk about a little bit later. Monitoring is absolutely key to the well-being of these individuals with thalassemia. And you have to monitor for iron overload, and that involves an MRI, and we'll see why an MRI specifically and not just doing ferritin levels. Monitoring for side effects of the chelation therapy, that's important as well. It's either weekly or monthly, depending on which chelator you're on, as well as monitoring for complications of the disease and the treatment itself, which is done annually or more frequently if they've already developed these complications. Non-transfusion dependent individuals have mostly a supportive care need for their bone health. Vitamin D and folic acid supplementation is oftentimes required, and thromboprophylaxis if they have been splenectomized and have evidence of vascular disease. A splenectomy, again, in individuals who have severe anemia and splenomegaly, sometimes doing a splenectomy may ameliorate the anemia for a little bit. But again, as I mentioned before, we're moving away from this because of the predisposition to developing vascular disease once you are splenectomized, because the abnormal cells that are coming out of the bone marrow don't get cleared by the spleen, which has been removed. Transfusions may be necessary on a periodic basis if the individual has leg ulcers has progressive splenomegaly with the aim to suppress the erythropoiesis, extramedullary erythropoiesis, and reduce the size of the spleen during pregnancy or around times of surgery or infections or other stressors like that. Iron chelation therapy is necessary despite these individuals not being transfusion dependent because they tend to absorb increased amounts of iron from the gut as a result of the ineffective erythropoiesis, and therefore need to be on iron chelation therapy as well. So they need to be monitored for iron overload and treated when they are in that situation. Induction of fetal hemoglobin has been tried by pharmacologic means. Hydroxyurea, 5-azacitidine, decitabine, and butyrate have all been used with varying success. Those are things that are more individual therapies that can be tried depending on an individual's preference as well as clinical status. Luspatercept is not yet approved for use in non-transfusion dependent patients, though clinical trial data in phase 2 showed that it did have an impact on increasing hemoglobin levels for these individuals. But the more definitive study, the phase 3 trial, is still underway. And then stem cell transplantation is available to these individuals as well, and gene therapy may be a curative therapy in the future as well. The complications of beta thalassemia you can see on this slide, and essentially you have transfusion-dependent patients on one side and non-transfusion-dependent patients on the other side in terms of their complications. And for transfusion-dependent patients, the complications are mostly related to the iron overload. So you can see here the endocrinopathies, cardiac disease, liver disease, and osteoporosis, all related really to the iron overload. The osteoporosis has other etiologies as well, but most of these are related to the iron overload itself. Yes, they can have transfusion reactions, develop alloantibodies, and which make it difficult to cross-match. So those are also issues that these individuals may have to deal with. And then the non-transfusion dependent patients mostly have complications related to the vascular disease, the vasculopathy that results from the abnormal cells causing vascular endothelial damage. So you can have silent cerebral ischemia and silent strokes. You can develop pulmonary hypertension and right-sided heart failure. You can develop venous thrombosis and leg ulcers. All of those are the vascular complications. You might also have other complications related to iron overload, such as hepatic fibrosis, etc., due to hemolysis, such as gallstones, splenomegaly as a result of the extramedullary hematopoiesis, which may also lead to masses or pseudotumors that can impinge on the spine and cause other sorts of problems. And then osteoporosis, again, multifactorial as a result of expansion of the bone marrow, as well as bone disease from the endocrinopathy and iron overload as well. So we'll talk about a case here. And so this is a 38-year-old man with beta thalassemia major who comes for evaluation of increasing splenomegaly and hepatomegaly, worsening back pain, and a recent onset of bilateral leg weakness. He receives 2 units of blood every 5 weeks. His pre-transfusion hemoglobins are somewhere in the 7 to 7.5 grams per deciliter range, with the reference range for an adult male being 13 to 17. His peripheral smear shows numerous nucleated red blood cells and increased polychromasia. So the question is, how would you choose to manage this patient? Would you increase the frequency of transfusions? Would you do MRI of the spine and increase the frequency of transfusions as well? MRI of the spine and a surgical consult for splenectomy, nerve conduction studies and increased frequency of transfusion, or a surgical consultation for splenectomy only? Please pick your option, vote.
We've launched the poll, and just a reminder, the poll is anonymous, so don't be shy. Go ahead and vote. Okay, I'm going to go ahead and close the poll and share the results.
Okay, very good. I'm happy that the majority of you got the right answer. Oh.
Just click inside the presentation.
Okay, so yes, that is the most appropriate answer here. The goal of transfusion therapy in beta thalassemia is to suppress the ineffective erythropoiesis. It's likely that in this case, this individual has inadequate transfusion. His hemoglobin is only 7 to 7.5 pre-transfusion. He has a massive spleen, and he also likely has extramedullary hematopoiesis with the risk of paraspinal masses, which are causing some cord compression. So, the usual target that we recommend to maintain these individuals' pre-transfusion hemoglobin is somewhere between 9.5 and 10.5 grams, and this individual is being woefully inadequately transfused, as a result of which he likely has these extramedullary hematopoietic masses. And so he would need to have an MRI to confirm what's going on and make sure that there's nothing else that's causing that back pain and sciatica. And then probably increase his transfusion frequency to suppress his bone marrow, suppress that ineffective erythropoiesis, and those masses would resolve on their own. So that would be the way I would go. A splenectomy may have to be considered, since if the spleen is very enlarged and increasing the transfusions does not help that much because the spleen is chewing up the red blood cells more rapidly. So it's possible that a splenectomy may be necessary as well, but I would start with the MRI and increasing the frequency of transfusions. So let's move on to talk about iron overload now. So both non-transfusion dependent patients and transfusion dependent patients develop iron overload. In the transfusion-dependent patients, this is what you see after about 16 units of packed red blood cells have been transfused. Most of the iron is still sequestered safely in the reticular endothelial system and in the liver, both of which are normal storage sites for iron. As you remember, when you have red blood cells that become older and deformed, the reticular endothelial system, the macrophages, take those cells out of the circulation, and then usually the iron is recycled back to the bone marrow for incorporation into new red blood cells. But in this situation, since you're not making new red blood cells, the iron tends to accumulate. And so it's taken up by the liver or stays in the RE system. This is what happens after about 100 units of red cells have been transfused, where the macrophage monocyte system or the RE system has been completely overwhelmed, filled up. The hepatocytes have been pretty much filled up, and iron is now remaining in the circulation and being taken up by other parenchymal cells like muscles, the heart, endocrine organs, where the iron will deposit and cause problems. So when we think about iron loading, the normal amount of iron that you take is about 1 to 2 milligrams. The normal amount of iron that you absorb if you don't have thalassemia is about 1 to 2 milligrams per day. And you excrete about 1 to 2 milligrams per day because you don't really need to have that excess amount of iron because it's being recycled. Iron that is in thalassemia individuals, the iron is taken up. You have more iron absorption from the gut because of the ineffective erythropoiesis, and then it's also received as transfusions, which overall will add up to about 25 to 30 milligrams of iron per day. So 1 to 2 milligrams of iron a day is what individuals without thalassemia would be getting into the system. Here you have about 20 to 30 times that amount of iron coming in on a daily basis. Iron excretion, however, remains the same because iron is excreted in the urine, in stools, as well as through sweat and epithelial shedding. And that remains about the same. So under normal circumstances, individuals with thalassemia who get regularly transfused are accumulating about 20 to 25 milligrams of iron per day. And that is going to add up because a normal size adult has about 5,000 milligrams of iron. And if you're getting 20 to 25 milligrams a day, that's about 0.5% per day. And that's going to add up very quickly. In 100 days, you'll get to, you'll have doubled your iron concentration. The toxicity of this iron is dependent on the level of iron in that tissue, the sensitivity of that tissue, because all tissues are not equally sensitive to the effects of iron. As I mentioned, the heart, the endocrine organs, and the liver are most sensitive, and the duration of time for which the iron overload persists. So the longer the iron remains in that particular tissue, the more likely it is to be damaged. So all individuals will load their liver. This is a normal storage site, and therefore iron does accumulate in the liver in all individuals if they haven't been treated. And over time, again, with long-term exposure and high levels of iron, it leads to fibrosis, cirrhosis, and a risk of hepatocellular carcinoma. Hepatitis C is an independent risk factor and has an additive effect on the iron in terms of the risk of fibrosis and cirrhosis. The heart is particularly vulnerable, especially in individuals with low levels of hepcidin being the master regulator of iron metabolism, and hepcidin levels are low in individuals with ineffective erythropoiesis, and that's what leads to the increased absorption of iron from the gut. And these individuals who have relatively low hepcidin levels do load the heart and the endocrine organs as well. In the heart, you can have contractile dysfunction, usually starts off diastolic, but eventually leads to systolic dysfunction as well as conduction abnormalities leading to a variety of different arrhythmias. Endocrine abnormalities could lead to involve pituitary dysfunction, particularly in children where you have impaired growth and development, a delay in achieving puberty. The endocrine pancreas might be involved, and that might lead to diabetes. You have gonadal dysfunction, osteopenia, hypothyroidism, hypoparathyroidism. All of those organs are particularly sensitive to the effects of increased amounts of iron. Now, we do need to monitor the amount of iron in tissues because you need to monitor how quickly it's going up. We need to decide when to start chelation and how to monitor chelation. We know that all tissues don't take up iron at the same rate, and so we need to look at that differential deposition of iron in tissues. And the best way to do this currently is to be able to do this by measuring the iron in the tissue by MRI. So we can measure the hepatic iron concentration by MRI, either an R2 or an R2 star, and then convert that number to an actual milligrams per gram based on data that we already have. The normal upper limit of normal for the hepatic iron concentration is 1.6 milligrams per gram dry weight of liver tissue. The cardiac T2 star measures it doesn't tell you exactly how much iron is in there, but it gives you in milliseconds what that would correspond to. So under normal circumstances, the cardiac T2 star is greater than 20 milliseconds. Some would like it to say 25 or 30 milliseconds. And then pituitary and pancreatic iron is also measured by MRI, but that's not really standard of care. Keep in mind, liver iron concentration higher is worse. Cardiac T2 star lower is worse. And this is why we don't rely on the ferritin level alone. As you can see here, this is a correlation between the liver iron concentration on the y-axis compared with the serum ferritin level on the x-axis, with a good correlation and a significant p-value. But if you just looked at somebody whose ferritin level is 1,000, that might correspond to a normal liver iron concentration, a liver iron concentration that's 5 or 10 or 15 or 20 or even 30, all with the same ferritin level of 1,000 micrograms per liter. So not a reliable way of measuring the body iron concentration. You might use it to follow trends and see whether or not if the trend is going up, you might say, I might need to increase this person's chelation therapy, so let me do an MRI. Ferritin is also affected as an acute phase reactant, so again, not very reliable if you have a fever, if you have some other kind of infection or inflammation in your body. So something that we still use, but only really to see what the trends are, to determine when to do another MRI and then decide what to do with an individual's chelation therapy. So as I mentioned, the MRI is the standard of care now. It is non-invasive, no irradiation is involved, and it's easily accessed in the developed world. The caveats are that there is significant technique variability depending on the machine and depending on where it's done. The sensitivity is very good at lower levels, but at very high levels, the sensitivity decreases. And we know also that it doesn't correlate well between tissues. So you can't say, I'm only going to do the liver MRI, and I'm going to assume that if the liver is better, the heart is better as well. And you can see that here in this graph here on the lower right-hand side, where you have the liver iron concentration on the x-axis and the cardiac iron concentration on the y-axis. You can see there's no correlation whatsoever between these two. So not something that you can rely on just doing one or the other. You have to do both in terms of monitoring. These are the iron chelating agents that are available. Deferoxamine at the bottom was the first chelator to be used clinically in these individuals starting in the 1960s. Unfortunately, it has to be given by a subcutaneous infusion over 8 to 10 hours every night because of its short half-life and because it gets digested in the gut if you take it orally. Needless to say, because of this route of administration, compliance was not very good. And so many of the older individuals with thalassemia have significant complications related to the iron overload as well. Deferoxamine was approved in the United States in 2005 as Xjade, and then again in 2015 as Jadenu. Xjade is a dispersible tablet. Jadenu is the film-coated tablet that can be swallowed. And then for children, you have sprinkles as well. And then deferoprone or Feriprox was approved in 2011 in the United States. Initially, it was given 3 times a day, and now we have available a twice-a-day formulation as well, which should result in significantly improved compliance because individuals were missing a middle dose of Feriprox when it had to be taken 3 times a day. So deferoxamine is the longest used approved effective iron chelator. The challenges, as I mentioned already, and because of the route of administration, it can lead to significant infusion site reactions and pain and a high degree of non-compliance at the same time. Studies have shown that survival, if individuals with thalassemia, was directly correlated with compliance with their iron chelation therapy. So that's the lifeline. That's what keeps them going and keeps them from having morbidities and mortality. And now it's mostly used for combination therapy because it's not used as a primary chelator anymore, and used in combination with either of the other chelators to enhance the iron excretion and reduce and more aggressively reduce the systemic iron burden. Deferoprone or Feriprox was approved by the FDA in November 2011, as I mentioned. It's primarily used right now as a second line and in combination, though with the new formulation of a twice a day, it may be used more as a first-line drug as well. It is effective in reducing the liver iron concentration, but may be more effective than the other drugs in removing cardiac iron. It does have some side effects: the nausea, vomiting, abdominal pain, and non-specific things like headaches and stuff like that. Arthralgia and arthropathy are seen, and these are particularly worrisome complications, especially in individuals of Asian ethnicity who might have a higher predisposition to developing them. But the most worrisome complication or side effect is neutropenia, which can become very severe, leading to agranulocytosis and a significant risk for infection and sepsis. And that's the reason for requiring a weekly neutrophil count or an ANC determination to make sure that that's not happening. So this can be used as a single agent, and it is used as a single agent in individuals who, at least was used specifically as a single agent in individuals who couldn't tolerate deferoxamine, but now can be used as a single agent on its own as first-line therapy, or it can be used in combination with other chelators as well. And then deferoxamine, again, as I mentioned, approved in 2005 and 15, orally effective once a day with a wide therapeutic index and therefore a wide range of doses. The side effects are nausea, vomiting, and abdominal pain, significant liver and kidney toxicity risks, and therefore monitoring monthly for liver and kidney function. Rare cases of neutropenia and agranulocytosis have been reported as well. And it has been demonstrated to have an efficacy in cardiac iron removal as well. Good long-term safety and efficacy data. So this has been the single agent first-line drug that has been used since its approval in 2005. Though now we might see other drugs also being used as first-line therapy, not other drugs, but specifically Feriprox or deferoprone. Again, as you can see, survival in thalassemia is dependent on effective chelation, and if you effectively chelated, then your survival was pretty good. You lived into beyond 25 for sure. If not, then the mortality started about age 15 and then would go down quite significantly in the next 10 years or so. So we have another case at this point. A 16-year-old Italian girl with beta thalassemia major presents with lethargy, She had a splenectomy 12 years ago. Her recent MRI showed iron overload with a liver iron content of 25 milligrams per gram and a cardiac T2 star of 10 milliseconds. Her chelation regimen is a combination of deferoxamine and deferriprone. On evaluation, she has fever, pallor, tachycardia. Laboratory parameters show leukocytosis and urinalysis suggestive of a UTI. So what would you do? You start antibiotics, and which of the following is the most appropriate next step in managing this patient's iron chelation therapy? Continue both chelators, decrease the dose of both chelators by 50%, discontinue deferriprone and start deferrocyrox, discontinue deferroxamine and start deferrocyrox, or hold both chelators. Please vote now.
Okay, we've opened up the poll. Don't be shy. Okay, I'm going to go ahead and close the poll and share the results.
Excellent. Again, most of you got the right answer, and that is to hold both chelators. And why do we do that? So iron chelators can potentially worsen an infection by making iron more available to certain bacteria. And most bacteria, or all bacteria, require iron to thrive. And providing them with that iron by taking it out of cells and into the circulation just makes it available to these bacteria if they're in the circulation. And therefore, it's recommended that the administration of all chelators be suspended when any patient has a fever. Chelators may be restarted after the patient has been afebrile for 48 hours, and it has been determined that the infection is not as a result of especially certain bacteria that are particularly iron avid. So stem cell transplantation is the next thing we'll talk about. It is currently the only current available curative option. Pre-transplant organ function and iron status is critical. We know that younger patients tend to do better. Excellent outcomes are noted with matched sibling donors, including umbilical cord blood from matched sibling donors. 85 to 95%. More recent data shows higher rates of overall survival and about 90-95% transfusion-free survival. And then if you went with a mismatched or unrelated donor, then the levels actually, the survival actually goes down quite dramatically. And so we in terms of who is a good candidate for transplant, we're going to say younger patients and patients who have matched related donors. At this point, I certainly don't recommend going to transplant if you have very high iron levels and if you've already suffered significant morbidity from the iron overload. And I certainly don't recommend going to transplant with an unrelated or mismatched donor. There are non-myeloablative regimens have been used and are in clinical trials and continue to be in clinical trials. These are looking to see if you can reduce the toxicity related to the myeloablative conditioning regimen, particularly the infertility and the risk for clonal disease. And then alternative donor sources are being used also in clinical trials ongoing, including haploidentical donors, which some studies have shown reasonably good results in as well. So only curative option currently and to be recommended to individuals who are in good shape and who have a matched family donor. Overall survival, without treatment, individuals with beta-0 thalassemia would die in the first 2 to 5 years of heart failure related to the severe anemia that they have. Non-beta-0 individuals have variable complications, and survival is not quite as low as that, but they don't tend to do very well overall as a group unless they get supportive care and comprehensive management as well. But they can survive into their 20s and 30s and 40s even, but may become transfusion dependent at some point in time. With treatment, there is improving survival. There is significant morbidity, but even those morbidities are actually going down because most of those morbidities are related to the iron overload in transfusion-dependent patients, as we saw already, and in non-transfusion-dependent patients to the vascular disease, which we're monitoring for, not doing splenectomies. And so that's improving those morbidities as well. And deaths are usually related to the complications that I mentioned. And so if you look at this Kaplan-Meier plot, depending on your birth year, so if you were born in the 60s, your mortality was quite low, starting at about 10 to 15 years, because they didn't have chelation therapy at that point. In the late 60s, you started to have chelation, and so you did a little bit better. And then, as chelation regimens got better and better and better, you're seeing improved survival as well. And we expect that individuals who are now treated and chelated with the oral chelators should have near normal life expectancies as well. So overall, we've come a long way. We've improved the safety of the blood supply, reduced the incidence of alloimmunization by doing extended phenotyping of red cells when we're transfusing somebody chronically. We have oral iron chelators. We have improved monitoring of iron overload by MRI. We've improved treatment for those individuals who developed hepatitis as a result of transfusions. And we have improved outcomes for stem cell transplantations as well. So we've come a long way, but there still remain significant unmet needs. We need to have a way of ameliorating this ineffective erythropoiesis, which could reduce or sometimes eliminate the transfusion requirement, in turn reducing iron burden and therefore complications of iron overload as well. We want to reduce bone disease, we want to improve quality of life, and we need to have more curative options for those individuals who don't have match sibling donors or match-related donors. And so a variety of different novel therapies have been in clinical trials more recently. You have gene therapy as curative therapies, including gene editing therapies to increase fetal hemoglobin production. The many hepcidins have been used to try and ameliorate some of the iron overload related complications and improve the efficacy of erythropoiesis. Those are in clinical trials as well. And then there's a whole bunch of other ones. Luspatercept we'll talk about in a little bit more detail because it has been approved. Pyruvate kinase activators, phosphodiesterase 9 inhibitors, as well as JAK2 inhibitors have been used. JAK2 inhibitors were used in a phase 2 clinical trial, which was terminated, and I don't think that that's going to make any further progress. But we'll talk about many of the other ones in a minute. So luspatercept is what we'll start with. This is a recombinant fusion protein containing a modified extracellular domain of the activin receptor 2B. What the activin receptor 2B does is it binds to TGF-11. This is one of those members of the TGF superfamily of ligands, which I mentioned in the beginning, which accumulate when you have ineffective erythropoiesis. And what these ligands do is it inhibits SMAD2/3 signaling. What the ligands would otherwise do would be to increase SMAD2/3 signaling, resulting in an impairment of differentiation and maturation. And if you can remove this GDF11 by trapping it in with this activin trap or this receptor, then you can inhibit the SMAD2/3 signaling, and that would promote red cell maturation and differentiation. And early studies, both in animals, phase 1, phase 2 studies, showed efficacy both in transfusion-dependent patients as well as in non-transfusion-dependent patients. So the BELIEVE trial was a pivotal trial that led to the approval of this drug, and I'm not going to go through this in detail, but you looked at luspatercept compared with placebo. The individuals are randomized 2 to 1. You could increase the dose. 1 milligram is the starting dose. You could increase it to 1.25 if you didn't think they were responding, or you could increase it to see if that would work. And this trial lasted 48 weeks, and then they switched over to an open label trial in which individuals were able to cross over as well. And essentially, these are the results. And when you look at the primary endpoint was to compare the proportion of individuals between luspatercept and placebo who would have a reduction in transfusion requirement of 33% from baseline in a specific time point, which was the weeks 13 to 24, which you can see down here on the left bottom. So that was the primary endpoint. The secondary endpoints were looking to see if you had transfusion reduction in weeks 37 to 48, any 12-week period, any 24-week period of 33%, or 50%. And as you can see from these graphs, both the primary and all of the secondary endpoints were met with statistical significance comparing luspatercept to placebo. So conclusions were that the BELIEVE trial did meet its primary and secondary endpoints with statistically significant reduction in transfusion requirement compared to placebo. It was well tolerated, the most frequent adverse events being bone pain, joint pain, and dizziness. Subsequent analysis has shown that there is efficacy in patients with all genotypes, and there is an improvement in patient-reported outcomes in the responders as well. Luspatercept was therefore approved by the FDA in November of 2019 and the EMA in 2020. Ongoing trials include non-transfusion-dependent patients, which is the BEYOND trial, as well as in pediatric patients with transfusion-dependent thalassemia as well. So let's talk about another case now. This is a 28-year-old non-splenectomized Asian female with beta thalassemia who presents for a follow-up visit. She's been receiving 2 units of packed red cells every 3 weeks. Pre-transfusion hemoglobin is between 9 and 10, in the range that we like it to be. She has iron overload with a liver iron concentration of 12 milligrams per gram dry weight, and she's on deferosarox. How would you choose to manage this patient? So 2 units of blood every 3 weeks. Would you continue her current treatment regimen? Would you perform a splenectomy? Would you discuss luspatercept, or would you refer to gene therapy? Please answer. Vote.
Okay, I'll go ahead and close the poll and share the results.
Okay, good. So this is an individual who is doing reasonably well, except, I'm not particularly happy with the liver iron concentration of 12 milligrams per gram. I'd prefer to be somewhere in the 2 to 5 range. But otherwise, she's getting transfused every 3 weeks or so. Her hemoglobin is maintained in the range that we would like it to be maintained for the most part. So she's doing okay. But you want to reduce her iron level. You want to, you can increase her iron chelation, or you can try to reduce the amount of iron that she's getting through her transfusions. And so you can try and reduce her transfusion requirements by thinking about luspatercept and seeing if that would work or not. So I think we talked about all of this. Splenectomy would achieve a reduction in transfusion requirement, but it would come with all those other complications that I mentioned as well. And therefore, you would try luspatercept, which is the indication for which is the treatment of anemia in adult patients with beta thalassemia who require regular blood transfusion. So transfusion-dependent patients, a patient who has continuing anemia, which she has, and that's why luspatercept might be used to reduce her transfusion requirement. Okay, mitapivat is another pharmacologic agent that has been shown in early phase trials to be effective in thalassemia individuals. And what it tends to do is it tends to increase your pyruvate kinase level in your developing precursors, and therefore increase ATP levels in red cells as well as in the red cell precursors. And so this is able to ameliorate ineffective erythropoiesis and therefore iron overload, as well as anemia in the mouse model of beta thalassemia. And so this schematic just shows how it does that by enhancing ATP and reducing ineffective erythropoiesis. So the trial in adults with non-transfusion dependent thalassemia, alpha and beta thalassemia was carried out, early phase trial, mostly looking at safety. And these were the results. So the primary endpoint was an increase in hemoglobin level from baseline by 1 gram per deciliter. And the primary endpoint was met in 92.3% of patients, which is shown here. 13 out of 14 patients responded. And the mean increase amongst all comers, alpha and beta, was 1.34 grams per deciliter over baseline. In alpha thalassemia, the response was a little bit less robust, 1.17. In beta thalassemia, 1.43. But 92% response rate was pretty good. It took responders about 3 weeks or so to, as a median, to show that response. So a positive endpoint here, I think proof of principle, and therefore phase 3 trials are in planning or underway for using mitapivat in transfusion-dependent as well as non-transfusion-dependent patients. The hepcidin pathway has been targeted as well. Remember, most of these individuals have an abnormally low or inappropriately low level of hepcidin as a result of the ineffective erythropoiesis, and that leads to increased iron absorption as well as iron redistribution to different organs. Hepcidin mimetics would then, the hope was, function to improve ineffective erythropoiesis, reduce iron absorption from the gut, as well as reduce iron to the different organs from the hepatocytes where they're and macrophages where it is normally stored. So there are two agents that are in trial. LJPC401, that was trialed to see if you could reduce the cardiac iron concentration and increase the T2 star, and that did not meet its primary endpoint, was abandoned. And then the Transcend trial of PTG 300 for both transfusion-dependent and non-transfusion-dependent patients with thalassemia is still underway, and we don't have any recent results from them as well. TMPRSS6 is part of the hepcidin regulation pathway, and this is another target that has been used to potentially decrease iron overload as well. And so these are in planning for clinical trials as well. But what we spent the last few minutes talking about is gene therapy. And there are different approaches. There's globin gene addition, where you can add a functional beta globin gene or add a functional gamma globin gene. And then there's gene editing, where you can reverse fetal hemoglobin repression by knocking out BCL11A, which is the gamma globin expression repressor. Or you can actually correct the beta globin gene mutation itself by this editing process. And how does gene therapy work? Essentially, you have to harvest stem cells from the bone marrow following mobilization by apheresis. And so individuals will get plerixafor to mobilize the stem cells, and then apheresis to collect the stem cells. Then they're sent to a lab where they're transduced or edited. So you can either transduce it with a vector that carries the gene of interest, a lentiviral vector, or you can edit them using various techniques. And then these modified stem cells are reinfused after conditioning. What is currently used is full myeloablation, so myeloablative conditioning regimen. And then the modified stem cells are reinfused, and they can be, and if they engraft, then they can start to function as well. So we'll talk about some of those trials. You have gene addition, you have the lentiglobin BB305 vector, which is the Bluebird vector, which they conducted the North Star trials for. Early studies with 204 and 205, and the more recent studies, phase 3 studies, have been 207 and 212. We'll talk about those in a minute. And then the Globe lentiviral vector, which is in phase 1/2 trial, which is the one in Italy, where they inject the modified bone marrow directly into the bone marrow. Gene editing, the modified stem cells, I mean, are injected directly into the bone marrow in the Globe trial. And then gene editing, you have two. You have the Sangamo trial, which is the ST400 or Thales study. And then you have the CRISPR-Cas9 gene editing trial of CTX001. We'll mention each of those in a minute. So these were the early lentiglobin trials, and you can see that both individuals with beta 0, beta 0 and non-beta 0, beta 0 did have responses. 12 out of 13 of the non-beta 0, beta 0, and 3 out of 9 of the beta 0, beta 0. But even the ones who did not achieve transfusion independence, and the blue lines here are transfusion independence, and the orange lines are patients who are still requiring regular blood transfusions. And you can see here that, and so this is a mix. You can see here that even individuals who did not respond to, did not become transfusion independent, did have a reduction in transfusion requirement, which was quite significant, except for this one patient here. You can see all of these patients who were who did not achieve transfusion independence did have a reduction in transfusion requirement as well. These are the later trials, the 207 and 212 trials of lentiglobin, and you can see here the 207 is in non-beta 0 beta 0 patients, and you can see again the blue lines indicate transfusion independence. So you have this one patient who achieved transfusion independence and then became transfusion dependent again, lost the graft essentially. But the others have become transfusion dependent and have remained transfusion dependent, at least the ones who have been able to be assessed at the time point for transfusion independence. And then these are the beta 0 patients, and you can see here that these results are definitely better than the earlier trial results. You can also see here towards the right that the hemoglobin levels of these individuals were actually a bit higher than the ones you can see here. And so, you know, overall, these two trials had about a 90% transfusion independence in these individuals with both non-beta 0 beta 0 as well as beta 0 beta 0 thalassemia. This is the phase 3 study in pediatric patients, and you can see that they have also had good responses. These two individuals did not respond, and they continued to receive transfusions, but the rest of them have all responded. Again, you can see fairly good hemoglobin levels of 10 for the most part, some at lower levels, but for the most part around 10 or so, which is where we try to keep them with regular transfusions as well. And so in this safety trial, 24 patients, and in the efficacy trial, 15 patients, you can see that, again, dividing it up between the greater than 12 years and the less than 12 years, of the greater than 12-year-olds, all of them had a response, whereas in the less than 12-year-olds, 2 did not have a response, and the rest did have a response as well. We'll talk about the adverse events in a minute. Gene editing performed the same way. You harvest stem cells, you send them to the lab, and then you can either disrupt BCL11A using zinc finger nucleases or using CRISPR-Cas9. And these are the two different ways of doing this. Or you can edit the beta globin gene, the beta globin locus itself, using CRISPR-Cas9. And so these are the two approaches. The first approach is in clinical trials, whereas this one is still a little bit farther away from clinical trials. The delivery of the edited gene is the same way, in terms of mobilization of the hematopoietic stem cells and myeloablation. And then this is distinct because it's a non-viral delivery. You don't have a viral vector that is required to do this, and you're editing the gene directly using either CRISPR-Cas9 or zinc finger nucleases. These are the results from the CRISPR TDT trial, and you can see here that of the 7 patients, you have a transfusion independence in these patients who could be evaluated, 5 out of 7. The other 2 have not yet had not yet reached the 6-month mark, which is what's required as the endpoint to determine transfusion independence. But you can see very good hemoglobin levels, 13, 14, and the light blue here shows fetal hemoglobin, because what you're doing is you're knocking out BCL11A, allowing fetal hemoglobin expression, and therefore you have predominant fetal hemoglobin in these individuals as well. Again, you can see here in the patients who showed this response, 5 out of the 7 have met that 6-month mark, good hemoglobin levels, and the longest that the first patient has been out, and this was as of December of last year, is about 20 months or so. So in general, the gene addition trials have achieved transfusion independence in about 90% of patients in the more recent studies, especially successful in individuals with the non-beta 0 beta 0 genotypes. There have been no deaths to date, and the adverse events are pretty much related to the myeloablative conditioning regimen. Otherwise, in general, it's pretty well tolerated. Obviously, we don't have that much long-term data for the individuals who were treated with the more recent 207 and 212 studies, but we have about 5 years worth of data in the earlier studies, the 204 and 205, and those individuals are holding, so the response does seem to be durable. But there are some individuals, as you saw from the graphs, who had a poor response as well. Targeting BCL11A gene editing has shown promising results already, and the same safety profile in terms of the adverse events being related to the myeloablative conditioning. So to summarize, this is an expensive treatment. It does have its adverse events and short and long-term morbidities associated with the transplant process. And so availability, expense, risks have to be addressed very, very carefully with individuals as well. And finally, I'll just spend 1 minute talking about transition. As we know, the transition from pediatric care to adult care has substantial changes, has substantial challenges, primarily because you have a whole bunch of things happening at that time. There are changes in the patient, physical, psychosocial, reduced supervision, peer pressure. The family and the patient may both not be prepared for this. You have a relationship with your pediatric hematologist for 20 years, and then you have to move on. That requires preparation. There's some anxiety amongst parents, and internists may not have a whole lot of experience dealing with this particular chronic illness in adults. Specific to thalassemia care, most comprehensive centers are in children's hospitals, and the transition involves going to a different facility from a children's hospital to an adult hospital. Late adolescence is when this happens, and it is a time when compliance is very severely tested in these individuals. They may have delayed growth in puberty, they may have chronic psychosocial issues, and then they risk losing a stable relationship of many years with a pediatric hematologist. They may go off to college. They have a new team of subspecialists as well. And then, this agent, luspatercept, is only available to adults over the age of 18. So if you're in that transition age, you may not have the ability to get it in pediatrics, but now it's a whole new world once you go to the adult side as well. To ensure a smooth transition, we recommend starting the process early, assessing for readiness for transition, counseling both the parent and the child, having time to provide learning opportunities for both, empower the child to make educated decisions over time, take charge of his or her own care. Having some overlap with both providers is ideal at 19, 20, 21. And then keeping the channels of communication open: patients, parents, pediatric provider, adult provider, support staff, nurses, social workers, etc. All critical to ensure a smooth transition. With that, I'm going to come to the summary slide. It is a chronic condition with significant morbidity and impacts quality of life. Monitoring and treating iron overload has significantly improved. Stem cell transplant outcomes are better. Targeted therapies have great potential to alter the natural history of the disease and improve quality of life for patients. And curative gene therapy is certainly on the horizon. And I think that's the last slide. I'm going to stop there. I'm sorry I ran over a minute or two, but I'm happy to take any questions and can stay as long as you need to. Thank you.
Dr. Sheth, thank you so much for an excellent presentation. We really appreciate it. You do have some questions. If you click on the chat icon down the bottom of the screen there.
So I should stop sharing.
Yeah, and then just click on the chat.
Okay.
And then I think the easiest way, there's a couple questions in here. The easiest way for you to find them is I will tell you the time that each of them came in. So if you look up at 7:15, there's a question there. Okay.
Do you place all of your thal-majors in vitamin D and folic acid supplementation? For patients who are regularly transfused, I don't do folic acid because there's no reason to do it. You're not going to become deficient if your marrow is suppressed adequately and you're not really utilizing that much extra folate. In the non-transfusion dependent patients, I do. Vitamin D, I check levels and supplement those individuals who are deficient, but I don't routinely empirically put everybody on vitamin D.
There's another question at 7:25.
Yes, if your hepcidin level is normal and you don't load the heart and endocrine organs, or that doesn't occur. Hepcidin level is always low because they have some level of ineffective erythropoiesis. So hepcidin levels are typically low, and therefore these individuals do tend to, the more severe transfusion-dependent individuals do tend to load the liver and the heart. because their epsilon levels remain inappropriately low and therefore allow iron to go into these organs, to leave the safety of the macrophage and the hepatocyte and go to these other organs. Again, the more iron overloaded you are, the higher the risk of it going to these organs. If your iron is under control, if your iron levels are under control, then it usually stays in the macrophage and the liver and doesn't go to these other organs. But once you get beyond a point, then it starts to spill out.
I'm sorry, question is 745.
745. The ones that don't have functional hemoglobin, this is an absolute excellent question. What is probably happening is that whatever cells are coming out are surviving better. The fetal hemoglobin levels did not really go up that much. So what we're seeing is not the increase in hemoglobin is not as a result of the increase in as a result of increase in fetal hemoglobin. So it's not really clear what those beta 0 patients are actually making. But whatever cells are coming out will survive better. And we do have evidence that these individuals are, that their hemoglobin levels do go up in the non-transfusion dependent state. So they do tend to work in the non-beta 0 patients in terms of promoting this. But in the beta 0 patients, yes, we did have data that showed that there was a response, and maybe it's having an effect on the survival of red blood cells, the transfused red blood cells, as well as whatever cells are coming out of the bone marrow with the fetal hemoglobin and the hemoglobin A2. So an excellent question. I don't have a good answer for you. I don't think anybody has a good answer for you, and we're still looking into that.
So you have two questions at 8:01, and I see there's some two questions in the Q&A box, so we haven't forgotten you. We'll get to those, but in the chat section, there's two questions at 8:01 and then one at 8:06.
How do I manage patients with non-compliance? I try to convince them that their lifeline, patient's lifeline, is being compliant. And if you're not compliant, you're going to have complications. And I go on and on and on. I give them read them the right act oftentimes, and when they have their MRI, if I get a result that is worse than their previous one or is still not in the good range, then we have a serious sit down conversation and say, this is really affecting you adversely, and so you have to do better with that. My combination, I've used all three combinations: Desferal and Jadenu, Desferal and Feriprox, as well as Feriprox and Jadenu. So all three combinations have been used, and depending again on why you're using combination, is it a side effect profile that you're worried about? So if I'm worrying about kidney toxicity, then I'm not going to do. Then I'm going to focus more on Feriprox and Desferal, and not so much on Jadenu. So you have to decide based on side effect profiles, etc., in terms of what you do. I check vitamin D levels twice a year, and supplement as necessary. With regards to gene editing, when do you expect this to be a routine option? Oh, I have no idea. This is a the clinical trials have to be completed. There has to be a certain amount of follow-up that is required by the FDA before it will get approved. So I'm going to say at least 3 or 4 years from now, I think, at least.
And then Dr. Sheth, if you look at the Q&A box, the two little bubbles there, there's two questions in there, and I think that's it.
The first question again, some Reblozyl treated patients report feeling fatigue despite having high hemoglobin levels. Are the red cells that are making with Reblozyl normal, functional? Is there something different about them? We again don't have a good answer. It's very difficult in a transfused patient to distinguish the cells that they're making on their own and the cells that are being transfused. So it's very hard to actually tell what is going on. We'll have a better answer once the non-transfusion dependent trial has been completed, but right now it's very hard to tell whether that's true or not. Have I used luspatercept in pediatric patients? No, it's not approved for use in pediatric patients. So I would, you can start using it at 18, 19, 20, depending on the need. But yeah, not in pediatric patients. Can't be used.
I think that's all the questions. It's a great presentation with a lot of great questions. Thank you so much, Dr. Sheth. And again, thank you to the Cooley's Anemia Foundation.
Yeah, special shout out to the Cooley's Anemia Foundation. No, luspatercept is not approved for 12 and above. Luspatercept is only approved for 18 and above. It's only approved for adult patients, unless something happened in the last month that I don't know about. But otherwise, it's for adult patients only so far. So thank you all for your questions, and a special shout out to the Cooley's Anemia Foundation. Keep up the good work. It's amazing what you guys do.